But he had some kind words to say about me. I'm not a smart or successful man. The only thing I guess I was successful at was just to deceive him to think that I'm actually a good guy. But we'll go ahead with my presentation today. It's going to be diabetic eye disease. So just as a, I was given to pick a brief topic on I was given to talk on a brief topic that we most commonly see, and one of the things that's very prevalent in our community is diabetes. Now, when people get diabetes, it's just not a matter of you having high sugars and we keep the sugar under control and everything's fine. It's actually a very devastating disease. In fact, the statistics are that 1 out of 3 babies that are born today will be a diabetic, just given the society and the culture we live in. And just because it's such a common condition to have, we kind of say, oh, everybody has diabetes, but sometimes patients get cancer, and if it's a family member, we get devastated. Oh my God, my uncle has cancer. This is dangerous. But sometimes it's actually better to have certain types of cancer than diabetes, just with the amount of patients suffering. What I see all the time in my office is the eye manifestations of diabetes, and that's what I'll show you today. So diabetes, just to refresh, it's a condition where the sugar in the body is very high, and what happens is that when we eat something, everything has a little bit of sugar in it, whether it tastes sweet or not. When we eat something, it gets broken down into sugars. We have a mechanism inside our body that addresses the sugars that need to be broken down. And thanks. So when we eat something, a substance called insulin from our pancreas, which is in the abdominal area, gets released, and the insulin breaks down the sugars, gets metabolized, gets broken down into energy, and that's how we get energy to move around. The problem in diabetics is that the body cannot produce either enough insulin to address the amount of sugars in the body, or that the cells cannot respond to insulin. The most common symptoms that patients get is, I've written here polyuria, polydipsia, and polyphagia. What polyuria means is if you feel like you're urinating more, very frequently, such as you're getting up at night, feel like you have to urinate a lot. Patients who are diabetics also feel like they're always hungry. And it's a vicious cycle. They can't break down the sugars, but yet they're always hungry. And that's very thirsty. And polyphagia is when they're very hungry. So diabetic retinopathy means a problem in the retina, which is a part of your eye, because of diabetes. That's what diabetic retinopathy means. I'll show you a lot of pictures about what diabetic retinopathy looks like. But patients who have had diabetes for more than 10 years, roughly 80% of them will have diabetic retinopathy. So at the very least, patients who are diabetics should see their eye doctor or any eye doctor at least once a year. And the reason for that is that 90% of these cases can be reduced with proper screening and proper treatment. So if you catch patients who are diabetics who have problems in the eyes early enough, if you start treatment early enough, there's a good chance that you will not go blind. But I have patients who are diabetics who are not even 20 years old and are blind in both eyes, legally blind. And I'll again show you what that stuff looks like. So when I say diabetes, or diabetic retinopathy, again, that means a problem in the retina, which is a part of the eye, because of diabetes. And these are just some very fancy, technical sort of terms that it can manifest in. One is, diabetic retinopathy, non-proliferative or proliferative, macular edema, which is swelling inside the retina, vitreous hemorrhage, which is a big blood, spotch in the eye. You can get a retinal detachment and neovascular glaucoma. Now, before I show you pictures, when I say the retina in the eye, for you to understand that, think of the eye as an old-style film camera. So when the film inside the camera is the equivalent of the retina inside the eye. So it doesn't matter what kind of camera you have, if the film that you're using is bad, even if the camera is a $10,000 camera, whatever pictures you take are not going to be good. And the retina is directly communicating to the brain, is connected to the brain. So the retina captures the image, whatever, like all of you are looking at me or the presentation right now, The image is being captured by the retina and being connected and transferred. The image is being transferred to the brain, and your brain understands, okay, I'm sitting here looking at, this image here. So if there's a problem in the retina, you're not going to be able to capture the image. So this is just a basic structure of the eye. This is an eye looking towards the left. If you were to pull the eye out completely out of the socket, these are all the muscles. There are a total of 6 muscles that hold the eye. And if you were to cut the eye right in half, which is this picture right here, you can see the back part of the eye is all lined with the retina, which is what we just talked about, like the film in the camera. And again, the eye's looking towards the left. And right here, when patients get cataracts, this is the lens, an innate lens that we're all born with, that gets very cloudy and opacified. So when patients get cataracts, when we go do surgery, we remove this lens, clean that area up, and put an artificial clear plastic lens so you can see better. And everything behind that, again, is the retina. When we look into the eye, we look, from the left side in, that's how we look, and this is what we see, this is what I see when I look into your eye. This is all a picture of the retina. This is the very center part of the vision, which is called the macula. This is the nerve. So I said the retina is connected to the brain, and the nerve is like a wire that connects the brain to the retina, so the retina captures the image, and that image is transmitted to the brain by means of that nerve. So it's very important for that nerve to be healthy as well. This is something that also gets affected in patients who are diabetics. Again, the macula is the center part of the vision. Patients who, you might have heard macular degeneration and such, this is where the problem occurs. So there are 2 pictures here, picture on the left and picture on the right. The picture on the left is a normal retina, which is what it should look like. Again, the macula and the nerve or the optic disc, synonymous. You can see there are no hemorrhages. In the picture on the left, you can see these white spots, which are small areas of their strokes. They're called cotton wool spots and exudates. And there are all these hemorrhages as well. And that's, again, most commonly because of diabetes. Here's a picture of a non-proliferative diabetic retinopathy. Now, you saw 2 pictures that look normal, so you can see what's abnormal here. You see all these hemorrhages. So this person, in 1 year, if untreated, has a 50% chance of loss of vision, whether it be a tremendous amount of loss of vision or a little bit, but will eventually, if untreated, within 10 years, will go blind. Here's another picture of diabetic eye disease, and you can see the nerve, as I said, can be affected, and there are all these blood vessels that are growing here that shouldn't be growing here. In fact, the retina is also starting to lift up, as we talked about getting a retinal detachment. That's what you're seeing here. So one of the things that we do for patients who come in with a picture like this is offer them laser treatment, because if we don't laser them, again, they will go blind. Here's a picture. All these white circles that you're seeing all around are burn marks from having laser treatment. So hopefully this person doesn't progress to get more vision loss. This is a patient here sitting at a laser machine. The laser is not done in surgery. It's actually done right inside the office. And this is what it looks like. Here's a patient getting a laser treatment. Now here, another picture, just what what laser treatment looks 10 years down the line. You can see the burn marks in the back of the eye that are actually turning dark now. And there's a partial laser treatment that you can see here. Here's a nerve. There are blood vessels. Again, all this hemorrhage here, all these blood vessels growing around the nerve. Again, if you don't treat that, the retina will continue to detach. Here's a patient who had very bad diabetes, as you can see here. Again, the nerve, the big hemorrhages. After he got lasered, you can see how much more clear his retina has become. This is 5 years after he's been lasered. This is, of course, before the laser treatment. And you can, again, see the amount of swelling, the blood vessels growing out from around the nerve and what we call elsewhere. And again, after the laser, the eye has quieted down substantially. Again, very difficult case, a bad case. This patient is practically blind in this eye. you can barely see where the nerve is. There are blood vessels that don't even look normal at this point. All this white stuff you see here, that's all scar tissue where the retina is trying to detach. This patient has had laser treatments. You can see these brown spots. But this is someone who I would take to surgery, go in there, remove all this white stuff that you see, the scar tissue, which serves like a scaffold for the retina to detach on, and hopefully, maintain whatever vision they have. Unfortunately, by this time, even after doing major surgery, spending 3-4 hours in the operating room, the patient will not see that much better because it's already after the fact. The purpose of doing surgery here is to maintain whatever vision they have so they can somewhat function. This is a good case. As I said, I would take that last patient that we saw to surgery. Very similar picture here. You see these white membranes. This is a patient that went to surgery, came out of surgery, and you see all those white membranes are all gone. They've been removed. Again, the vision usually lags. These are all, again, old, burnt out laser marks. Laser is probably one of the best things you could do to diabetics in long term. When we talk about doing surgery, this is what it looks like when I operate. This is the eye. It's open. This is a view under the microscope. I usually make 3 holes in the eye. 1, 2, and 3. This is an infusion port because the eye is like a grape, except as soon as you put a hole in it, it's going to deflate. It's going to turn into a raisin. So you need to keep the pressure in the eye, stable while you're operating. So this is an infusion port connected to a big tank that keeps a certain amount of fluid coming in to keep the eye inflated. And this is my left hand, my right hand. My left hand is usually a light because it's very dark inside the eye, so you need to have light inside the eye. And this is a blade, scissor that I go in and cut these white membranes that we saw. And it's all done under a microscope, so you can see here the patient's lying down. Here's the first, the primary surgeon. Usually there's an assistant also. It's very technical, and a lot of times we need help of an assistant, so we have another doctor that's usually an assistant. And you can see the anesthesiologist there probably checking the stock market while the patient's under the anesthesia. This is another type of surgery that we do for patients who have retinal detachments. Here's the eye that's been completely exposed, and I have these are sutures and they're ties made of silk, and we pretty much pull up the eye, and you can see that there's a scleral buckle, which is a membrane, almost like a belt that we compress the eye with to support the retina. So just some more pictures. This is a picture of what I see again when we're doing surgery, and those white membranes that we saw earlier. Here's my scissor, and you can see I'm trying to pick up a membrane over there. I'm just trying to pull it off without causing any holes or any tears inside the retina. This is, again, the retina that you're looking at on a patient that's being operated on. Normally, when we see patients who go into surgery for retinopathy, which is, or retinal detachments, it's very common to see, if you ever inspect their legs or something, this is a big eroding ulcer. All this is, just granulation tissue, and, from not having enough blood supply going there, it's actually dying out, it's gangrene, Patients commonly that we operate on will say, oh, doc, next month I'm having my legs amputated or toe amputated. It's all, again, as I initially told you, it's not just about, having high sugars and that's it. It affects every part of your body, literally. You mentioned vitreous hemorrhage. Here's a big area of just blood sitting in the back of the eye. Again, this is just background diabetic or non-proliferative diabetic retinopathy that I showed you earlier. This is some very advanced stuff going on with hemorrhage. Now, if this becomes very big, this is something, again, that a person would need surgery for, to go into the operating room, remove all the hemorrhage, and hopefully the patient can see a little better. This is a retinal detachment. You guys saw earlier pictures, but again, a patient that requires surgery because all this is retina that's coming off. If you don't put that back in time, this patient 100% will go blind. Here's a picture of the front part of the eye, and again, the blood vessels and all this bleeding we saw in the back, you can also see some blood vessels growing in the front part of the eye, these red lines are blood vessels. This patient would most commonly come into my office in excruciating pain, wouldn't let me examine, usually throwing up, nausea, vomiting. This is an attack of glaucoma that this patient would have. Normal pressures in the eye, maximum should be around 20. This patient would have about a pressure of 80, 400 times more. And this also needs to go to the operating room immediately. Again, a very similar picture in the front part. You can barely see anything inside the eye because the front part, which is right behind the glassy part of the eye, the cornea, is all full of blood just from diabetes. It's called neovascular glaucoma. This is a patient who presented, had never had any treatment with diabetes, no laser, had blood in the front of the eye, was very painful, never again went to an eye doctor, just kind of managed himself, with the pain, took Tylenol, whatever, to keep him comfortable. You can't even make out that there's an eyeball here because this eye, it's done. It's dying. You can't do anything for this eye except to remove it. And again, this is one of the worst things that you can see with diabetic eye disease. So what does a patient see when they have diabetes? When it's very advanced, this is what we would see, a picture of two kids. This is what a diabetic will see, and you can see the difference in the details. So a lot of times, we'll be walking around in a supermarket, or if someone bumps you, the normal instinct is to get angry, like, hey, what are you, blind? Like, you didn't see me here? But sometimes, there are people walking around with this sort of vision, and they can't see you, So just kind of put things in perspective there. A little less, severe, but again, here's what someone who without diabetes will see, someone with diabetes will see. Another picture of what a diabetic, would see every time they look at it. So at a certain point, we have to evaluate if these patients should be on the road driving, because if if their vision is like this, it's very easy for them to run a red light or to hit someone or get into an accident, hurt themselves, hurt others. So we have to recommend and request that their licenses, get suspended for some time. One of the new medications we have of bleeding that we do most commonly is, this is just, again, intravitreal just means to put it inside the vitreous cavity, which is the back part of the eye. And anti-VEGF, it's a specific group of medications that we inject for diabetes. When they come into the office, one of the first things I'll do is just give a shot right to the eye, and this is how it's given. Just give a very small needle and just inject the eye, and usually stabilizes the patient for 3 to 4 weeks. I can get my lasers or surgery in, and then it gives a better outcome for the patients. Again, this is another gentleman here who's undergoing a laser treatment for the diabetes. And that's pretty much it. Do you guys have any questions?
I have a question.
Yeah.
If there's an infant that has diabetes, at what point do you recommend that they get eye exams?
That's a good question. Kids have very aggressive diabetes, juvenile onset or type 1 diabetics have very, very advanced diabetes. They're not gonna start getting diabetic retinopathy in their first few years of life because this is a chronic condition. So the statistics are that by the time someone's diagnosed with diabetes, an adult I'm talking about, they've probably had diabetes for a few years before they actually get diagnosed. But when you're talking about type 1 diabetics, those are the patients that I'm extremely aggressive with because they progress very fast. I just told you earlier when I started my talk that I have just recently had an 18-year-old or 19-year-old boy who presented to me with diabetes from birth, and he's blind in both eyes. And the most I can do for him is to maybe get some more vision. But had that patient started his eye care maybe at the age of 7 or 8 with an ophthalmologist, and they kept a very close eye, I feel like a lot of that stuff could be controlled. But that's probably one of the most aggressive sort of diabetic and most difficult diabetics to treat.
Because as a baby, I'm thinking there's probably only so much testing you can do with a baby, right?
Yeah, but there's only so much testing, but it's, I've seen babies that are 23 months old, not years, months, and these are tiny babies. They're about this big, but yet we can manage to get a complete eye exam. And I've operated on babies that are about 28 months old. So
you're really never too young to come in.
Exactly. That should never be an excuse.
Okay.
And let the physician be the judge of that. Never make that sort of a decision yourself. And because it's something that if you find out 10 years later that this could have been prevented 10 years ago, it's something that you're going to have a very difficult time living with.
Right.
Okay.
Thank you.
Sure.
Couple of questions. Number one, what age should a person be starting getting their eye examination? This is a very unusual condition that a child is born with diabetes. So standard, what is the recommendation? Number two is that with the macular degeneration, I think there's an injection that's recently come out. Canadian have been introducing it.
Sure. To answer your question in the order they're asked, one is at what age? Usually it's not a bad idea for a child at the age of 6 or 7 to get a regular, just a basic eye exam. Not necessarily for diabetes, because it's very uncommon, as Dr. Faruqi said, to have a child or a baby with diabetes. But one of the things that we worry about with kids is something called amblyopia. And some of the obvious signs that if the parents say, Doc, every time I take a picture of my child, one eye, I can see the reflex is red, but the other one is white. These things are very worrisome. If you see anything abnormal with the eyes, don't ever think that it's just by chance, because kids can have cancers like retinoblastoma and such that can present like this, very subtle, and if they're not treated, a child can die from this. But again, that's also very rare. I'm not trying to scare you, but to answer Dr. Faruqi's question, at the age of 5 or 6 is good, because the way the human body is that a child's circuitry, because the eye is like a circuitry where you guys are all looking at me and it's going to the brain. If that's not fully developed, that connection between the brain and the eye, you have up until the age of 12 to 13 to really address that. Because once you're past that stage, and that's usually what happens, is the kid is 17 years old and he's like, Doc, every time I do this, I don't see too well out of my left eye, which he's pretty much blind out of, but I see very well out of my right eye, and I never knew it because I have 2 eyes. So I got around perfectly fine. I'm like, oh, I wish I saw you at the age of 10, because we could have done some patch therapy to get the other eye to start seeing. But usually after the age of 12 or 13, you can't treat amblyopia. The second question Dr. Faruqi asked was injections to the eye for macular degeneration. Macular degeneration is the leading cause of blindness in the elderly population in this country. And up until just a few years ago, we really had no good treatment. So even though it was a leading cause, patients went blind. Like, we would see them say, oh, I have a treatment which is a laser, I'm going to burn the back of your eye. It's going to make your vision worse, but I'll feel good because the disease is not active. But the patient's like, well, I'm going blind and you're going to blind me faster, and that's what would happen. Now we have these injections that we inject every month, and it reverses the bleeding process. It doesn't reverse a macular degeneration, but in macular degeneration you get bleeding in the eye. It reverses that and maintains vision. The new product, I think probably might be referring to something called ILEA, which is a VEGF trap. Again, just some technical terms, but this is what the molecule is. These injections we do pretty much almost once a month. For the first year, and then start, if we can extend out the treatments, say once every 6 weeks, once every 8 weeks, and some patients will do that. With ILEA, the advantage of this new medication is that you can inject it once every 2 months. So that's...
What age should we start worrying about the macular degeneration? Very serious problem, because elderly folks get often depressed, they're withdrawn, they don't want to participate,
Sure.
and they just sit back, they're not active even though we push them to go and be involved. So this is something which could be prevented if it is started earlier.
Yeah, unfortunately, macular degeneration cannot be prevented. We can do our best to delay the progression once diagnosed. Macular degeneration is it's a very interesting thing, because initially the full name of macular degeneration it's called AMD, and the MD stands for macular degeneration, and the A is like age-related macular degeneration. But again, in my office, just in the last week, I saw 3 patients who were under the age of 40 who have macular degeneration. So in the youngest patient I've seen with macular degeneration is one of my office staff, who at 28 years old of age, we diagnosed her with macular degeneration. So there's really, that would be a Nobel Prize really, given how common it is to have, or the prevalence of macular degeneration, and yet no cure, so from a curative standpoint. But for the most common, I think what was understood is that over the age of 50 is a good idea to start screening. It's very prevalent in Ocean County. I see less of it in Monmouth County, but definitely in Ocean County it's very, very common in a lot of young patients. Things that are associated with macular degeneration is smoking, cholesterol, blood pressure. And there's some vitamins that we can give to, if someone has a high risk factor, say mom and dad has macular degeneration, we can start patients on vitamins, and we also do genetic testing in the office to kind of risk stratify, meaning, what would be your chances to get macular degeneration if anyone in the family has it. And all these things are usually covered by insurance, so we're doing quite a bit of that stuff too.
Two more questions.
Yeah.
One is for the children that come to school. We have a full-time school, we have Sunday school, we have a lot of children. So when should a teacher or a staff should worry about a child for the eye as a problem? And the other question, I just forgot, I'll ask you if I
Sure.
recall.
So with this question, kids start getting screened from kindergarten when they go to, private elementary schools, or whether it be private or public. And as soon as they fail a screening, even by the smallest bit, they'll immediately get referred out to an eye doctor, just for the reasons that we talked about. Because if a kid goes blind, you only have a small period of window to address that. So it wouldn't be an unwise thing to do just to screen everyone at in the kindergarten level here, just by putting up the 20/20 chart and just kind of assessing.
The next question was that what should we do as a person, as an average person, to prevent with the nutrition, any guide or advice for the vitamins which we should use in our daily lives, or whatever time frame? As you mentioned, you have some vitamin supplements recommended. I know often you prescribe them there over the counter.
Right.
So what is the particular vitamin or any nutritional supplement in the diet one can have to prevent or to get the vision better?
So nutritional supplements, I think if you had to just take one pill, no one here is going to take 20 pills or whatnot, but if there's one pill you have to take, I'll probably say it's an omega-3 fatty acid, or like fish oil tablets. They've been proven to really help not only with the eyes, but elsewhere in the body as well. I don't recommend you guys go out and buy any, macular degeneration vitamins. Vitamins are good, but at the end of the day, they're chemicals. So, macular degeneration vitamins are very high dose vitamins, and if you take anything without any objective in mind, the only reason you're taking that vitamin is to give you side effects from it. So, but as a health, preventive maintenance, Centrum's, multivitamin is good, along with some fish oil. These are probably what I would recommend. And of course, unfortunately, we, being in, predominantly, anywhere east from the Middle East community, are at a pretty high risk for getting cardiovascular events, which Dr. Faruqi is an expert on. And studies have shown that there's anatomical differences between the diameters and the lumens in our blood vessels compared to a Western person's blood vessels. So we are already born with a disadvantage. On top of that, our diet is not really the most healthiest of the diets. So I think just being aware of what you eat, I'm not saying never eat, unhealthy food or sweets. Of course, you're human, right? You should do that. But just kind of be aware of that as well.
Okay, you have talked fish oil. So I have seen fish oil is normally available in this market with gelatin, and gelatin is not halal.
Right.
I could not find fish oil with a tablet form. Do you have?
Actually, I've seen fish oil tablets, but a lot of them are probably coated in gelatin
So,
also.
What is the choice?
You can get omega-3 fatty acids that are non-gelatin, and anything you buy as a gel cap is going to be coated with gelatin. So again, depending on what, again, it's a religious sort of an argument and where you stand. I agree with you. You can call the manufacturer, see if their fish oil gelatin is from a substance that would be okay with you or not. It could be made from fish bones. The gelatin.
But normally I heard gelatin is always made of animal, and animal is not slaughtered here in Allah name, halal.
Right. So
I can.
Dr. Faruqi can help.
Two things. Number one, you can always ask for plant gelatin.
Which?
Plant.
Plant.
Plant origin, not animal origin. So they will tell you that if they use any animal, they use all animal. Number two, if you are looking for vitamin D or omega-3 fatty acids, you can buy krill oil. The liquid form does not have gelatin. So there's a liquid. Now third thing, there's a halal vitamin company has come out, and you often see in Islam, Muslim those channels, they advertise their product. So you can get the fish oil from them. But krill oil or the liquid form, the best way to fight this thing is also to expose the body to the sunlight. So also that generates vitamin D. But fish oil, just since you brought up, you should know it protects breast cancer in women. In my practice, I'm doing everyday vitamin D level, and I'm finding everybody is below standard. Normal range is 30 to 100, and I'm finding people as low as 8 and 6 and 15. Average people are hanging around 20, and it should be no less than 30 in the range, and it can go up to 100, so it's a big range. So we probably, people from the warmer country side and coming and living in Northeast, we already have a disadvantage to the weather and sunlight. So these things are very important. So fish oil, it is protecting, which is omega-3 fatty acids, which is also known as fish oil from the animal source. It is protective not just from the eye, which I just heard. I had read it, but he mentioned much more importantly, breast cancer, heart condition, memory, dementia. It is involved in a lot of processes in our body. So fish oil is very important, but we should not overdose it. That's also important. So you need to have a blood level checked.
Excuse me.
So,
I have one question. So many kids have now to a very high number of the eyes number. But what can I do? Because our English is not very high number, not in the diabetic. Usually 2.5, 3. Why is too much?
So you're talking about prescription numbers for glasses?
No, I'm talking about why kids is very early, very high number.
When
It's only
right,
the
but when,
year,
when you're
4
saying
year,
numbers,
3
you're
years,
talking
yes,
about the
yes.
prescription, correct?
Yeah.
So I wouldn't worry too much about that. The reason why for example, why I wear glasses is in optics, you see they're rays that come into the eye and they all have to converge into one point, and that's the point that's your sharpest vision. So the reason I wear glasses is because my eye is just a little longer than someone who doesn't wear glasses here. So in order for that convergence point to get all the way to the back, they kind of adjust for that in my lens. So just because you wear glasses or you wear very thick or very thin glasses, it doesn't mean that your eye is weaker than another. Now in kids, the reason why their numbers change a lot is because as they're growing, usually up until the age of 14 or 15, or up until even sometimes a few more years than that, the eyes continue to grow in shape. So your prescription changes because that point is kind of being tracked and it needs to land exactly on the retina. So if it doesn't land on the retina and it lands right in front of the retina, you need the lens to kind of change the refraction around.
Reflection.
It's mean high number is not dangerous.
No, absolutely
That's
not.
what I'm asking.
The only time, let's say if you have someone who's kind of entered adulthood, or even at the age of 25, at that time your numbers are very stable. And if you have very high numbers in the minus, meaning like a -10 or -12, those patients, just because the eye is so long, they need that much numbers, their retina is on stretch also. Everything inside the eye is being stretched out. So those patients will have slightly higher chance of getting a retinal tear just because everything is on stretch and everything is so thin. So that's the only important point I would want to make of that. But I wouldn't worry if your child is say, -5 or something
that's
right
what
now.
I'm
Yeah,
asking.
yeah.
It's very early. The 4 year is when -4, -5. That's what I'm asking. It's not that.
Right, and those numbers will continue to get more and more minus because usually when kids wear glasses, let's say, if they're -1, there's a chance that by the time he or she is about 16 or 17, they may go up to a -5 or a -6. It'll just get a little more minus because the eye is going to continue to grow.
You're saying that this image will fall in front, not in the
Right.
back, as they're looking from the front.
As the rays are coming here, the image should fall exactly where the tip of this arrow is. But in someone who wears minus glasses, their image falls right in the middle, right here. So you need to wear the glasses so the image can go here and everything all of a sudden becomes in focus. And if someone who wears a plus, like we have a couple of people here I can see wearing plus, the image falls behind the retina. And that needs to be brought up here.
So their eyeball is bigger than the socket, or socket is bigger than the eyeball, or what is it?
Well, the socket will always be bigger than the eyeball, but what it is the reason why you get these refractive changes for two reasons. One is that the eyeball is either too small or too little, or the cornea and the lens have refractive indices, meaning that they have the ability to make these rays. That's why when you get LASIK done, they don't give you glasses or anything because they just fix your cornea up so that your glasses are almost like embedded in the cornea where they can get the rays to fall right on the retina. So it's either the refractive or axial.
You had some question?
Yeah, actually you said that you should see the doctor once a year. So let's see if your blood sugar is under control. Whatever that 3 months HB2?
Yeah, H1C, hemoglobin A1C, sorry.
Is there any range you have to be more careful of? Or
Yeah, this is good. So the American Diabetic Association, Dr. Faruqi is still at 7.0. They're, yeah.
Yes,
Yeah.
6 to 7. They're coming up with 7.
I hope, yeah. So in the ophthalmology and the eye literature, it's not optimal to be even at 7. The eye studies show that you should really be below 6.5. Now, again, it's very easy for me to stand here and say it should be this, right? The person who's actually diabetic knows how difficult it is to get it down to that level. But from our standpoint, to see stability in the eye, we would recommend 6.5 or less. The American Diabetic Association is saying 7. It's still somewhat outdated because now we also have much better equipment to identify stuff that we never saw 10 years ago. So, for that reason, we recommend 6.5.
So if a person maintains a level below 6.5 or below, he or she should still go see the doctor?
Just the fact that you're diabetic or hypertensive, you should see, at the very least, your primary doctor who can take a look in the eye, assess everything's okay.
Well, you mentioned one thing about that everybody should go once a year checkup, but that's for people who do not have these issues. A person who has diabetes or blood pressure or other cardiovascular problems, or they are taking certain medication, they should have more than at least, I recommend my patient diabetic to go twice a year, and then the ophthalmologist advise them how frequent they should go. So if somebody is diabetic and is thinking that he's okay because he saw a doctor last year, that does not work. You should go to your doctor every 6 months for the eye exam.
Yeah, exactly. And I have a patient right now who's a diabetic, and his A1C is just around 7. He gets it at 7.1, 7.2, but he gets this injection almost every 2 weeks in each eye. So I see him more than like 30 times a year,
And normal range for A1C for non-diabetic is below 5.7 in Jersey. And 6.5 is what they are recommending, but then we should force them to bring down. But the another problem is that the recent study, I was in ACP meeting, they just mentioned that having a tighter control caused more complication because of the low sugar and whatnot. So getting a euglycemia, what you call the normal sugar level, is what we expect, not to get them forced down, because then that it has a diabetic problem, which is separate than ophthalmologic problem, which he's talking about.
And in addition to what Dr. Faruqi said, if you have someone, let's say, who's a newly diagnosed diabetes where the sugars were always running, 300, 350, and all of a sudden you slam him down to make him run 100, his eye disease is going to get out of control just with that sudden drop. They will proliferate much faster, and to the point where it'll require some real work done to their eyes.
So if you see the ophthalmologist, right, then you don't have to see the regular eye doctor because they can prescribe.
Ophthalmologist or eye doctor, it's only that he's retinologist. He's a specialized in retina.
Right, correct.
I don't know whether you mentioned it or not, because you need to introduce yourself properly. There are like primary care, internal medicine, then there are specialists. He is a specialist within the specialist. So eye doctor have a retinologist. He does very specialized care. So that's something very
Correct. And the other thing is that if you're, a lot of our community doesn't know this, but if you have an option, and if you have an option, try to go to an eye doctor whose name has an MD after the name. The reason is that there are other eye doctors. There's an optician who makes just glasses. Like, you take a prescription and they're gonna, fit your lens and all that. Then you have the optometrist who will measure for glasses. And a lot of times what happens is that the optometrist, if they feel comfortable, they'll start treating stuff like this. And when things go out of control, they'll call me and I'll say, oh my God, I wish you didn't do this because that was the wrong diagnosis. They're not physicians, but if their comfort level's there, they may go ahead and start treating certain things that they were not qualified to do. So if you go to and those optometrists, the degree is an OD, so that would define an optometrist. And if you go to an ophthalmologist who actually went to medical school and can treat some of this stuff, early stuff, that's why I recommend when you're going to an eye doctor, just make sure that it's actually a doctor and not an optometrist.
So basically, you are eye specialist, kids only or adults also?
I do kids and adults, babies all the way to adults, and within ophthalmology there's a subspecialty called retina and vitreous. So that's what I do. So I only, when you say the eyes, I do the eyes, but what I really focus on is just the back part of the eye.
Retina.
Exactly. Yeah.
There are very few retinologists in this area. So this is very unusual that we have one person in our community who's in it. Usually, when I was, for the last 20 years, I never saw one. So he's one of our people who was in there, which is a blessing. It is very, I don't know how hard it is to get into that, but it is very difficult to get into that. You gotta be
Okay,
ready.
my question is on macular degeneration.
Sure.
Can you define what it is for a layman? What are the
Sure.
symptoms and
So the eye metabolizes the most amount of energy in your body because even, for vision requires a lot of energy. So at the beginning of my lecture, we said, you eat some food, sugars, it gets broken down into energy, and certain parts of the body needs more energy, but it all gets allocated. What happens in macular degeneration, now again, you're looking at me right now, you see how my face is very sharp to you. Everything around you see, it's not really sharp, but you can see it. So the reason my face is sharp is my face is being projected right onto your macula. So that's why the macula is considered the central vision or the sharpest vision that you can have. In macular degeneration, when you have energy, the retina is thinner than paper, but it has 10 layers. And again, when it uses this energy for your vision, there are some byproducts called drusen that gets deposited underneath the retina. And that's the early stages of macular degeneration. When they get deposited underneath the retina, you start losing vision and things don't appear straight. My face will start appearing a little curvy. At that point, it's already getting pretty advanced. Macular degeneration, and that's called macular degeneration, when these byproducts deposit underneath the retina. You have two types in macular degeneration. One is called the dry, and then you have the wet macular degeneration. In the dry macular degeneration, we normally just treat that with vitamins and diet control. There's really no medications that we can give for that. But for wet macular degeneration, which is also very common, is what we do these injections for, and they help the patients. But it is a progressive condition, meaning any sort of degeneration, it's gonna get worse and worse and worse. Whether it be Parkinson's or macular degeneration, any kind of degeneration, it gets worse. The goal is to prevent it from getting any worse than what it is currently. But that's what macular degeneration is, when you get these byproducts of metabolism that gets broken down and deposited in your eyes instead of being absorbed.
And you said for kids, the vision grows, I think, till the age of 12 or 13.
For kids, the circuitry is being built. I'm not saying the vision. You can be 20/20 vision even at the age of 5, but their circuitry between the eyes, all the neurons, the connections between the eye and the brain is still growing up until the age of 13. So that's why you can address these issues before that.
So suppose if a kid is 6-year-old, as you said, and if his vision is not 20/20, so is there any chance it can grow to 20/20 by the age of 12?
There is a chance, absolutely, absolutely. But with treatment, if the vision is not 20/20 without treatment, there's almost a very minimal chance that his vision is going to be 20/20 past the age of 14 if you did nothing about it. And when we say vision, also keep in mind when we say vision is vision with glasses, because some, at least when I wasn't in medical school, I didn't know this either. Is, oh my God, I'm blind without my glasses, but when I put my glasses on, I'm 20/20. So do I see 20/20 or am I really blind? And when we say vision, it's always the best corrected vision. So it's vision with glasses or any sort of correction, contact lenses or anything.
You have a question?
Yeah.
Because
If
we need to
someone
have the second speaker also. Yes, go ahead.
Okay, family history of diabetic, will it affect someone is getting a chance of getting an eye problem?
A family history of diabetes?
Yeah.
A family history of diabetes increases your chance to get diabetes. And once you've been diagnosed, if you've been diagnosed with diabetes, then yes, you can get diabetic eye disease. But if your question is, can you get these problems from diabetes without having diabetes, the answer is no.
Okay.
No. These are very specific diabetic findings that I showed you today.
Thank you.
Any other questions? All right, so we'll ask Dr. Faryana.
I'll just get her presentation on this.
All right. Now, which medical school you graduated from, and can you?
So, sure.
Yeah,
I grew up in New York. Then we moved to New Jersey. I went through the public schooling system in Lodi, New Jersey. Then I went to undergraduate at Stevens and did some time at NYU. Then I went to Ross University, which is abroad. Then I came back. I did my internship in Brooklyn at Long Island College Hospital, and my residency and fellowship at State University of New York at Downstate. And I practice in private practice in New Jersey now, and I teach over at the medical school. I have an appointment there, but no longer am in New York.
So, which medical school you're teaching at?
SUNY Downstate.
SUNY Down?
Yeah.
Okay. And your wife, you would like to come up and introduce yourself, or he's going to introduce you to? I think you should.
I'm just gonna get her presentation on this with the whole.
Well, I think one important message take home is that we need to be very careful with our eye, and we are often negligent. We often are in denial that child may not have. If kids often do not progress in class, we need to always have their eye be checked out. And elderly folks, when they come in, they often say, "I don't have a problem with the eye." And they have a lot of, we didn't touch the allergy topic. I think she can touch on us the eye allergies, because that's very common. We live in Jersey. So allergist, immunologist are what we need most in this area. Particularly, we call it garden state, but this is really not a garden.
I don't want to pull this thing out because